Hi, I'm Joey Harmon, and I'm a learning consultant with the Bear Institute at Children's National. During this presentation, we'll be discussing the goals of meaningful use. At the end of this presentation, you should know what meaningful use of health IT means, what legislation was passed to create meaningful use, why was that legislation passed and why was meaningful use enacted, what is the criteria for the different stages of meaningful use, and what are some challenges that have accompanied meaningful use, and where is it going in the future? There's a lot to wrap our heads around when it comes to meaningful use. Since its initiation, a lot of buzzwords have surrounded meaningful use, and I think most healthcare professionals understand at a base level that this is something your organization has to comply with to get money. Well, meaningful use is a way for the U.S. government to ensure a return on investment for the incentives that are provided to providers and hospitals to encourage EHR adoption. This means that not only do you have to purchase and use an EHR to get incentives, but you have to prove that you're using it in a way that will ultimately benefit patients and the healthcare industry by improving costs, quality, and access. So how did meaningful use come to be? In 2009, Congress passed the American Recovery and Reinvestment Act, also known as ARRA. This was a $789 billion stimulus package that composed a substantial part of the budget, as seen on the bottom right of this slide. A large subcomponent of ARRA was the Health Information Technology for Economic and Clinical Health Act, or HITECH, which is much less of a mouthful. This outlined incentives for electronic health record adoption and allotted grants for federal agencies to create the necessary infrastructure to support these EHR systems. All high-tech related initiatives are administered by the Office of the National Coordinator for Health IT, otherwise known as ONC. Meaningful use is guided by the 5 pillars of healthcare outcome policy priorities. The first is improving quality, safety, and efficiency while reducing health disparities. We see lots of tools used in EHRs that make treating patients safer, like duplicate order checking, which is seen to the right. Other innovations like telemedicine reduce health disparities by allowing underserved areas to have access to specialists they might otherwise not be able to see in person. Second, meaningful use is intended to engage patients and family in their health. We see patients and their families increasingly involved in their care and corresponding more easily with providers using tools like the patient portal. Third, care coordination can be dramatically improved through health IT, aided by collaborations such as Commonwealth, which promotes interoperability and allows information to be shared securely and efficiently between organizations. Fourth, population and public health benefit significantly from EHR adoption. Better aggregation and analysis of patient information contributes to improved decision-making and helps ensure patients get the right treatment at the right time to manage their conditions. Lastly, these systems are intended to facilitate privacy and security of patient information. As we know, healthcare data is highly sensitive and breaches are a constant risk, so restricting access to data and creating cultures of security have gotten a lot of focus since meaningful use was implemented. So the overarching goals of meaningful use are to use software in a way that is meaningful and contributes to the goals of improving cost, quality, and access. The software should be used to share and access patient information in a secure way, and the certified EHR should also submit data that demonstrates adherence to the clinical quality measures outlined by CMS and ONC. So what is a certified EHR? To become certified, a qualified EHR has to meet criteria outlined by CMS and ONC. To be considered a qualified EHR, an EHR must include the patient demographic and clinical information. It must offer decision support, allow for computerized provider order entry, gather healthcare quality information in a way that can be queried, and exchange electronic information securely with other healthcare sources. You can visit the ONC website and find a list of certified EHRs. I've included a snapshot of some of Cerner's solutions and their dates of certification here. Meaningful use has a phased implementation, which began in 2011 with Stage 1. The emphasis of Stage 1 was on collecting data and sharing it with patients or other healthcare providers. For the first year of participation, eligible professionals only have to meet the requirements for and report data on a continuous 90-day period during the calendar year. For all subsequent years, providers have to meet requirements all year long. After their first full year of meaningful use Stage 1 requirements, providers can move on to Stage 2 of meaningful use. Requirements must then be met for 2 full years. Stage 3 became available for voluntary attestation in 2017, and now that the framework has been established, the goals shift more toward leveraging the EHR to achieve better health outcomes. Incentives for meaningful use are provided via increased Medicare or Medicaid reimbursement. This slide provides a glance at all of the professionals and organizations that qualify for meaningful use incentives. If providers qualify for both Medicare and Medicaid programs, they can only enroll in one. Incentives vary for the programs, as seen here. Medicare offers $44,000 over 5 years for early adopters, but less for those who start later. Additionally, providers can receive up to $4,400 extra dollars if they practice in a health professional shortage area. By contrast, Medicaid offers nearly $64,000 over 6 years, and providers can receive incentives during the first year simply for implementing or upgrading to a certified EHR. Incentive payments for hospitals are decidedly more complex, depending on whether they are pursuing Medicare or Medicaid incentives. One important thing to consider is that hospitals with multiple sites still count as one eligible hospital, so individual facilities under one umbrella can attest for meaningful use dollars separately. The formula for calculating hospital incentives is fairly complex, but begins with a $2 million base payment and then fluctuates based on patient volume. The general formula for arriving at this incentive payment is allowable costs multiplied by the hospital's Medicare share. To achieve meaningful use, providers and hospitals have to meet a combination of the criteria outlined on this screen. There are 15 core objectives that providers must meet, 14 for hospitals. Providers and hospitals then have the option to choose 5 of 10 menu objectives that they will also satisfy. Furthermore, providers must report on clinical quality measures which don't necessarily have a threshold that needs to be met, as opposed to the core and menu objectives. Lastly, the provider or hospital attesting for meaningful use must have records for 80% of their patients in the certified EHR. On this slide, you see the first half of the meaningful use core measures. The items in bold are measures that must be met by eligible hospitals. Among the items, you see features that are mainstays of modern electronic health records, such as CPOE, e-prescribing, drug interaction checking, and increased information sharing with patients. The latter half of the core measures focus on information that should be documented for each patient to increase the quality of their care. These items include current problem lists, medication lists, allergy lists, vital signs, and social histories, among other items. Providers and hospitals alike must meet 5 of the 10 menu objectives seen here, one of which must be a public health objective. Items 4 and 5 do not apply to hospitals. The third component of meaningful use criteria that must be reported is clinical quality measures, or CQMs. The measures shown here apply to individual providers and must all be met, in addition to 3 of 38 optional measures. Hospitals have a separate list of 15 measures that must all be met, focusing more on metrics like ED throughput, stroke management, and other acute cases. There are several benefits of meaningful use which are pretty apparent to those of us working in the healthcare field. Caregivers have access to information they need at their fingertips now to diagnose problems and provide patients with the best possible care. Coordination of care has been improved because information can be shared instantly across care communities, including physician offices, hospitals, and health systems, leading to better care. Patients are more engaged because they have the ability to receive their medical information electronically and share it securely over the internet, thus allowing them to take a more active role in their health care and that of their families. Patient safety has been improved due to electronic access to information about medications, allergies, conditions, and treatment history that can greatly reduce the risk of medical errors. Lastly, we're seeing healthier patient populations in communities because crucial data about diseases and outcomes is captured at the point of care, and it becomes available to other health professionals locally, regionally, and nationwide, which they might not have had access to previously. Although most healthcare professionals agree that meaningful use is for the greater good, there are also some challenges that we need to be cognizant of. The first is costs. Incentive payments for hospitals and eligible providers cover only 20 to 25% of the overall cost to implement an EHR and achieve meaningful use. Building a complete record can also require investments beyond the core EHR to include things like radiology systems, lab systems, digital imaging systems, and more. Enrollment and attestation can also be cumbersome. As more providers consolidate under healthcare systems, those systems have to manage getting their providers properly enrolled so they can demonstrate meaningful use and receive incentives. Creating a culture where providers are accountable for their meaningful use items and able to complete them without becoming overly burdened is a major feat for hospital and practice leaders. That leads into more tasks. Although EHRs are beneficial in many ways, there's also a perception that they slow down workflows and lead to physicians doing less clinical work and more administrative duties. This leads to lower patient volume, reduced revenue, or added costs for support staff to assist physicians. Obviously, some providers are more proficient or adapt better to new systems than others, but no matter what, the EHR has an impact on their livelihood. Lastly, access and security has become a major issue with EHRs. We've seen a dramatic number of cyber attacks on healthcare organizations and other industries that handle sensitive user data. When patient charts only consisted of paper and folders, providers didn't have to worry about someone across the world stealing their info and holding it for ransom, but that's a very real threat today. So staff have to be educated on proper use of hospital systems, access to certain data has to be limited, and an overall culture of security has to be established. Thank you for taking the time to watch, and I hope you learned something new about meaningful use. I look forward to new innovations in tackling the future of health IT in good company with all of you. Thanks again.